Hello, everyone.
Hello.
Hi, good afternoon.
That you already have the same issue
But
as before.
somebody's echoing.
Yes, I believe it's probably two devices just echoing.
Yeah, I only have one.
Very good. You're well prepared.
Hopefully, we shall see.
We are very,
Uh,
very honored to have you.
uh, nice to be here, but
Yes,
with technical things sometimes show up.
yes. I think that we still have maybe a moment, um, or shall I start?
It's fine with me if you'd like to start.
Yeah, we
Mm-hmm.
can start. It's fine with me
We can
too. Good
start.
morning.
Okay, fantastic. So, good afternoon, everyone. Welcome back to the second half of our today's program. We now begin the afternoon session with another series of insightful talks and poster presentations. Welcome back to the afternoon session. It is my great honor to introduce our next speaker, who is already with us, Dr. Gerald Katzman, who serves as a clinical associate professor and is widely respected for his contributions to the field. He will be presenting on child development leading to the pursuit of virtues and the avoidance of vices. Oh, I love this title. A topic that highlights the importance of early development in shaping ethical values and character. Kindly join me in extending a warm welcome to Professor Katzman. Professor Katzman, the floor is yours.
Okay, well, thank you very much. Let me start by sharing my slides. There we go. Okay, and then we'll. Okay. So, yes, the topic today is child development leading to the pursuit of virtues and the avoidance of vices.
I have a question,
Optimizing.
sorry to disrupt you, but I think the image of your presentation is a little bit cut, so we do not see the whole title, and it might influence the forward slides as well. So just
I can
um,
see the title. I can see the presentation completely.
the whole title. Okay, perfect.
Yeah.
Okay, perfect, perfect. Thank you so much. Please go.
Yeah, interesting. Now I'm not seeing the slides. I'm sorry, I changed. Um, okay, so you're able to see the slides right now?
It's okay. Now it's good. Yes, it's good now. Thank you so much. It's good.
Okay, I'll as I say, I'm just seeing myself right now. Uh, but okay, I will continue. So, optimizing social, emotional, moral, and cognitive development for all children is a goal towards which most individuals would agree is worth striving. Such an achievement would likely solve many problems that humankind confronts on a global basis. Examples of these problems include domestic abuse, avoidable enmities, some mental illnesses, crimes, wars, genocide, and others. Attaining benevolent mindfulness is a key result of a process leading to mature, healthy character development. At the same time, avoidance of insults that lead to selfish, malevolent behaviors is critical if human potential is to be optimized. This paper is meant to provide a roadmap to the process of fostering child development so that virtuous helping behaviors are the rule and vices actively avoided. I'm going to go to my next slide. Do you see the next slide?
No.
Yeah, I see that's the problem. I'm not seeing my slide change now that since I made a change, unfortunately. Oh, here we go. All right, now minimize this further. All right, now I think we're going to be all right. Okay. Now, authoritative parenting. Experts generally agree that authoritative parenting is critical to the healthy mental development of children. With this type of parenting, confrontation with responsiveness characterizes the approach to discipline. Confrontation involves identifying and counseling regarding misbehavior. At the same time, recognition and management of stress associated with misbehavior and certain life events is regularly attended to in order to prevent long-lasting adverse mental sequelae. Shaming, coercion, intimidation, and corporal punishment are not utilized as they are in authoritarian parenting. This is to avoid the toxic stress that is a product of preventable adverse childhood experiences. With authoritative parenting, the communication set up between parent and child leads to healthy interpersonal attunement that serves developmental progress. Unfortunately, authoritarian parenting often is passed from generation to generation. Adverse sequelae, including mental illness and violent behaviors, are often seen in future years. For this reason, an active effort to break the cycle of authoritarian parenting and teach authoritative parenting is vital. This effort may start while couples are attending prenatal education classes. In societies where authoritative parenting is not the rule, a child development team may be organized to promote desirable parenting practices. Lastly, permissive and uninvolved parenting also need to be avoided due to the lack of direction for desired behaviors associated with these parenting types. Now, with authoritative parenting, reciprocal communication between parent and child is established. In the newborn, this begins with en face or eye-to-eye contact, especially during feedings. Later, it may involve reciprocal smiling, singing, talking lovingly to the infant, and play activities before elementary communication with language is possible. The interpersonal attunement that develops describes how caretaker and child are responsive to one another's emotional needs, thoughts, and moods. When well developed, this interpersonal neurobiology involves a resonance where the thoughts, needs, and feelings of the other are regularly appreciated. Appropriate responses are often the result of such attunement and lead to the strengthening of the bond between caretaker and child. Now, imprinting describes a situation where a young animal comes to recognize another animal, person, or thing as a parent or other object of habitual trust, often shortly after birth. In humans, we usually use the term attachment to describe the trusting relationship that develops between child and caregiver. This trusting relationship strengthens over a period of months to years due to ongoing interpersonal attunement with caregivers being responsive to the child's needs. In order for attachment to be successful, an initial bonding of love and tenderness the caregiver feels for the infant needs to occur. As Andrea Hollingsworth has stated, over time, secure, attuned attachments with other persons may enable us to love more and fear less, rendering us progressively more capable of sharing in the suffering of others and increasing the likelihood that we will take action to alleviate their misery. It is these secure attachments that allow caregivers, teachers, and mentors to influence the child's developing mindfulness or intrapersonal attachment. Now, intrapersonal attunement or mindfulness involves noticing and respecting oneself. It refers to a self-regulation of attention where one pays attention to the events of the moment. The process requires an orientation to learned values represented in cortical areas of the brain. Intrapersonal attunement enhances the capacity for emotional empathy if certain values related to a particular circumstance are internalized. It is clearly necessary to provide a moral learning process that will enhance emotional empathy and serve as the impetus for helping behaviors. Developing a moral compass should insulate persons from blindly following a group who are caught up in inadvisable behaviors. Thus, moral learning should provide protection from de-individuation, so characteristic of authoritarian societies. Somehow we went backwards. Okay. Now, moral learning can be transmitted in a number of ways. Basically, the exercises involve either classical or operant conditioning. Every effort should be made to eliminate the corporal punishment and shaming that are commonly used by some, quote, educators in certain situations. Such reinforcement results in repressed fear and anger that serve as a well of energy waiting to be discharged on targets that may be established by false narratives. Moral learning is taught by either dilemma ethics or plain moral facts, with several vehicles commonly used for such teaching. These vehicles include the modeling of caring behaviors, reading stories with a moral, and human relations programs for children. Moral decision-making that results from such learning becomes emotional, intuitive, and automatic when dealing with a familiar issue. Alternatively, decision-making may involve conscious, controlled reasoning based on prior or new learning when an unfamiliar moral issue is encountered. Now, Samuel and Pearl Oliner's study, published as The Altruistic Personality, found that parents who modeled caring behaviors inside and outside the family were more likely to have children who would take significant risks to help others. Specific suggestions and techniques for modeling desirable behaviors are available through a number of sources. At healthychildren.org, suggestions include pointing out, sharing among adults, showing ways to calm down, teaching children to express their feelings, and paying attention to good behavior. At klaschools.com, suggestions for modeling involve doing good deeds, being patient in lines, respecting others and their property, and being a good loser. Other sites also contribute constructive ideas. Now, reading stories with a moral and that teach a lesson is an important modality also. Literacy is key to all learning. Early vocabulary growth comes with parents speaking frequently with their children. Brain growth is impaired when less words are spoken to children. The 0 to 3 program and others provide parents ideas for nurturing thinking and language skills. Unfortunately, across the United States, less than 50% of children are read to daily by parents. The Head Start program in the United States provides a vehicle for disadvantaged children to, quote, catch up. However, the program is inadequately funded and staffed to serve all of the many children in need. This lack of learning and impaired literacy in the early years may hinder the attempt to transmit plain moral facts through reading and telling stories. That is why promoting early literacy has the potential of enhancing the moral and social emotional development of children. There are many resources that caregivers and schools may use to promote moral learning as children mature. For the lessons to be appreciated and internalized, it is obvious that comprehension is mandatory. Now, individual differences and experience in human relations for children is an example of a compendium that outlines exercises at various grade levels to sensitize children to appropriate interaction with others. Multiple goals of the exercises include furthering self-esteem, supporting virtues, avoiding vices, control of emotions, awareness of human similarities, and respect for individual differences. A number of recent resources are available to teach respectful human relations. Many school systems do an excellent job in this area. However, it should be emphasized that there is a degree of moral entrepreneurship in all of these programs. Such moral entrepreneurship involves expressing an opinion as to what is virtuous behavior and what behavior should be avoided, i.e., vices. In this regard, virtues are defined as those traits of character that blunt mere self-interest so that one can see and actively promote the interests of others. In contradistinction, vices represent those traits of character that unleash mere self-interest so that one fails or ignores to see the interests of others. Certain cultures may vary somewhat in their concepts of virtues and vices. Teaching and agreeing on plain moral facts should be achievable. Now, false narratives have classically been a vehicle by which societies have attempted to direct members to accomplish their own selfish purposes. Such false narratives may distort history, promote false beliefs, and propagate negative feelings towards ethnic and racial groups for political purposes. It is anticipated that healthy psychosocial development that includes authoritative parenting and moral learning will shield persons from internalizing these false narratives and contribute to resilience in stressful times. Higher levels of literacy developed through the educational process should further facilitate the process of, quote, reading between the lines. There are communication skills that include attentive listening, assertive statements, and clear opinions that are essential to the success of nonviolent conflict resolution. Human relations programs for children should provide the basis for the objective thinking required to reduce enmities that have developed. Now, emotional empathy refers to the vicarious sharing of emotions. The ability to feel the emotional states of others is based on the quality of interpersonal and intrapersonal attunement experienced during development. Dr. Helen Reese has developed the concepts of empathic concern and empathic capacity. It is secure, attuned attachment, model behaviors, reading stories with a moral, and human relations programs for children that contribute to enhancing emotional empathy. Unfortunately, interpersonal relationships marked by conflict, insecurity, and distrust can cause us to feel threatened, emotionally deregulated, and closed off to empathetic connection with others. There are many examples where recurrent maltreatment in childhood that results in fear and anger produces a stifling of emotional empathy. The presence of cognitive empathy, the ability to mentalize without emotional empathy, is characteristic of psychopathy, where ruthless persons use others as objects to satisfy their own selfish needs. Now, emotional empathy allows one to feel the suffering of others. Moral learning creates the impetus to care about such suffering. The result of feeling one's suffering and caring about it is the desire to relieve the discomfort. That desire we define as compassion. It is compassion that leads to helping behaviors that ultimately relieve the suffering. The propensity to work towards helping behaviors is clearly dependent on the quality of experiences during psychosocial development. In conclusion, it is clear that optimizing psychosocial development is not a simple endeavor. If we are to achieve parenting for a peaceful world, significant initiatives are in order. Parenting orientation prenatally has been shown to be effective. Pediatricians can provide ongoing support to children and parents in the office if their services are readily available to all. Certain genetically transmitted conditions, mental disorders, congenital problems, and injuries require ongoing medical and community resources for the best possible outcome. The United Nations Convention on the Rights of the Child could provide a vehicle to further developmental education globally. There is much work to be done as the child advances through the school system. That work includes contributions from teachers, theologians, pediatricians, political leaders, and other community members who serve as role models for civility and responsible behavior. Indeed, it takes a village if psychosocial development of children is to be optimized. For progress to be made, countries need to provide the person power and financial resources to facilitate traversing the steps, which we're going to show in a diagram that tries to quickly show what we have experienced in the narrative. So this diagram is one that shows the process that hopefully leads to benevolent mindfulness. So we start with the interpersonal attunement between caretaker and child. This leads to secure attachment. The secure attachment sets up the situation where intrapersonal attunement may develop, and the vehicles of modeling caring behaviors, reading stories with a moral, human relations programs for children, all impact the development of benevolent mindfulness and interpersonal attunement. With authoritative parenting, the secure attachment, emotional empathy develops. This emotional empathy obviously will lead to caring behaviors, which ultimately result in helping behaviors. The human relations programs for children also enhances the possibility for a resistance to false narratives. The skills taught in the human relations programs hopefully will lead to nonviolent conflict resolution. Now, where we don't want to go is to malevolent mindfulness. Here is usually where authoritarian parenting leads to repressed fear and anger. That is the toxic stress that is often referred to. Permissive or uninvolved parenting in the presence of an authoritarian culture can result in the same type of toxic stress. This results in a stifling of emotional empathy, and in an authoritarian culture with group targeting via false narratives, hatreds may develop. And if this is reinforced further, this hatred may lead to violence. And if this is present in a large number of individuals in the culture, we see de-individuation, where a large number of individuals take part in this unadvisable behavior. I like to show, let's see what we can do here. Why is this? I need to stop the sharing. So I guess I didn't do. Let's see. Well, either. Oh. Okay. So, all right, I guess we did stop the sharing, and I want to try and show this video. It's a 2-minute video. We'll see if we can share it. There we go. We need sound. There we click the sound. Here's the video. And I will share it. There we go.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yes.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation. And
Okay. Stop share.
they're stuck in that really ugly situation.
Okay.
In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby.
Okay, that's my presentation. If there are any questions, I'd be happy to field them.
Yes, so I allow myself, first of all, Professor Katzman, to say thank you for this presentation, which was
You're
really
welcome.
very, very interesting and insightful and also inspiring. I allow myself to ask you a question. I just share maybe one, two things about me, so then you will understand. I'm actually working in mental health. I'm a clinical hypnotherapist. And one of the topics I'm very, very close to is combining digital health, artificial intelligence, and mental health. And the film which you just show us was really touching. What is very difficult, and I believe was at the end of this short film, is the question of the repair which happens. So my question to you is a question which comes from many parents, actually. how they can support their children. So I received this question, at which age they should give the phone to play with, knowing what you just have shown to us, that they will be on their phone completely disconnected from the child. So I would like you to take up on this, if you would allow me.
Well, the only thing I can say that and I have a grandchild who's in the sixth grade, and he doesn't have a phone yet. I would say that those early years are critical, and I think that if the process of authoritative parenting and the installation of moral compass takes place, then the phone is something to use for constructive purposes. The same with the computer. But if one becomes susceptible to certain adverse influences as development proceeds, then obviously we can veer off in the wrong path. And that's why parenting doesn't stop at 4 years of age. I mean, it's a long-term process. And the parents obviously need to be very much involved and aware of what's going on.
Mm-hmm. Yeah, this is a fantastic reply. Thank you so much for this. I have another question. So I also prepared, knowing about your field of research and interest, and speaking about or thinking about young children. What are the neurological mechanisms which are involved when the hatred is programmed into a child, and how we can prevent it?
Well, it's generally, as I understand it, and have read, it comes from an authoritarian culture. And two of the fascinating examples, I mean, hatred and violence sort of unfortunately go together. And if you look at the Spartan culture, the ancient Greeks, if you look at the Sambia of Eastern Highlands of I always forget but in the Far East it was a group Eastern Highlands of New Guinea. Interesting enough, both the Spartans and the Sambia at 7 years of age separated their children from the parents, and they introduced them into a violent culture where physical altercations were stimulated, where abuse was normalized, and the result was violent, non-feeling people. And what can I say? I think those are great examples of exactly what not to do. Unfortunately, that kind of authoritarian upbringing and programming goes on today in many places in the world, and I think is responsible for a lot of the conflict that we see. I mean, there's no reason that conflicts can't be resolved nonviolently. The only reason is another malevolent path has been stimulated, and it's hard to turn off.
Mm-hmm. Thank you so much for this reply. I allow myself another question. I don't see anyone else raising their hand for the questions. So my last question would be just regarding what you have mentioned. Do you think we can bring empathy building programs to measurably reduce long-term violence risk?
Well, it's certainly worth a try. I think, again, if those early years have been leading in what I've described as the wrong direction, very difficult to change. That sort of change does occur, however, and there are examples of very prominent figures in history that have made such a change for the betterment of their people. If you would like to read the book In Search of Identity, the autobiography written by Anwar Sadat, it is very inspiring, very inspiring. And there was someone who changed from a philosophy of violence to a philosophy of discussion and resolving problems through nonviolent conflict resolution.
Perfect. Thank you so much again for your presence and for the reply to these questions. And I would like to move forward to the next speaker.
Right. Thank you. Thank you for having me.
Thank you so much. So the next we have Dr. Claudia Andrea Arias, certified dental hygienist in Florida, United States of America. She will present on management of cleft palate, expanding access with the 3D printed devices. So please, can we join me in welcoming our next speaker?
Hi, good morning. Thank you for the kind introduction. My name is Claudia Andrea Arias. I'm original a dentist from Colombia. I live in here in the United States, working with a limited dental license, and I already have my dental hygienist license in Florida. Can everybody see my presentation?
Yes, we do.
Okay, thank you so much. Today, I'm going to talk about the 3D printing in healthcare, but we're going to talk about a specific transforming cleft lip and palate treatment through additive manufacturing. Okay. We're going to talk about fundamentals and technology, design and clinical outcomes, regulatory and future outlook. Understanding cleft lip and palate. Cleft lip and palate are congenital condition affecting approximately 1 in 700 births globally, resulting from incomplete fusion of facial tissue during fetal development. This condition impacts feeding, speech, hearing, and physiological well-being. Clinical impact: patients require multiple surgical interventions over years, with outcomes varying based on the surgical precision and time. Traditional methods rely on surgeon expertise and manual techniques, limited consistency and personalization. The innovation opportunity: innovation need customized patient-specific solution, can improve surgical planning, reducing operative time, and enhance functional outcomes, addressing critical gaps in current treatment approaches. Improve surgical planning, personalized approach, enable precision, preoperative visualization, and strategy development tailored to each patient unique anatomy. Reduce operative time, customized solution, streamline surgical execution, minimizing time under anesthesia and associated risk. Enhance functional outcomes, patient-specific intervention, optimize results for feeding, speech, hearing, and overall quality of life. Additive manufacturing principles. 3D printer builds objects layer by layer. from digital models and enable precise, customized production, unlikely subtractive manufacturing, additive process deposit material only where needed, reduction waste and enable complex geometrics impossible with traditional methods. Healthcare applications, medical 3D printer produce surgical guides, patient-specific implants, anatomical model for surgery, surgical planning, and prosthetics. Biocompatibility materials including titanium, PIG, and bioresorbable polymers. The design process for the cleft device. First of all, we have patient images, that is a high resolution CT and MRI scans, capture precise facial anatomy. The 3D models reconstructions, specialized software converts imaging data into digital models. We have CAD design and optimization, engineer refined models for surgical fit and functional requirements. Device printed. Additive manufacturing produces patient-specific surgical guides or implants. The clinical outcomes of 3D printed device. We have a surgical precision, more than 87% accuracy versus conventional, less than 35% reduction of operative time, more than 42% faster healing for patient recovery, and we have more than 56% improvement in speech and feeding for functional outcomes. Advantage of the 3D printer in cleft treatments. As I mentioned before, we have a personalization. Each device is custom designed for individual patient anatomy and eliminating one side fit, all limitation and enabling precise surgical planning tailored to unique facial structure. We have custom and time efficiency, reduce operative time 30%, 35% faster, and lower material waste. Decreasing overall treatment costs, faster production cycle, enable time intervention, particularly critical for pediatric patients. Precision and consistency. Digital design ensure productivity, high accuracy, surgical outcomes, eliminating variability from manual techniques, improving functional results and patient satisfaction. Challenge and limitations. The advantage that we have with this 3D device is customization, precision, speed, and consistency. The challenge, we have a high initial investment in equipment and software, material constraints, limited biocompatibility options, technical expertise required for design and operations, regulatory approval process are lengthy and complex. Talking about regulatory considerations, we have the FDA classification and the key requirements. The FDA classification, the 3D printed medical device, fall under Class 2 or Class 3, depending on risk level, require 510 pre-market notifications or pre-market approval. The key requirements: biocompatibility testing, sterility validation, design documentation, and clinical evidence demonstrating safety and efficiency. The certification timeline Regulatory approval typically requires 12 to 24 months, necessitating early engagement with regulatory bodies and comprehensive documentation strategies. Addressing materials and sustainability, biocompatible materials as titanium, alloys, and big polyether polyetherketone provides strength and integration. Bioresorbable polymers gradually dissolve post-healing and eliminate secondary removal surgery. Sustainability consideration. Additive manufacturing reduces material waste by 90% compared to subtractive methods. However, energy consumption and material sourcing require optimization. Emerging recycled material initiative and closed loops production systems are advancing and environmental responsibilities. The future trends in 3D printing. AI-assisted 3D modeling, machines learning algorithms, automate design optimization, reducing design time, and improving surgical outcomes through predictive analytics and patterns recognitions from thousands of cases. Custom implants and tissue engineering. Bioprinting enable creation of tissue-like structures with embedded cells, advancing toward regeneration solutions that integrated seamlessly with patient biology. And real tissue surgical guidance, augmented reality integration, overlays 3D models during surgery, enabling surgeon to visualize patient's anatomy in real time and adjust techniques dynamically for optimal precisions. The roadmap for adaptations. We have immediately that it's talking about 0 to 2 years. In this phase, we are talking about expanded surgical guides, adoption in major medical centers, established regulatory pathways. Near the term 2 to 5 years old, integrate AI assistant design, scale production capacity, and reduce costs by 40%. Medical terms, we're talking about 5 to 10 years old. This is the phase of mainstream hybrid implants, combining 3D printer scaffold with a bioprinting. And long term, we're talking about 10 years or more, fully regenerative tissue solution replacing traditional implants. As you can see here in the image, this is our model scan, additive model, and the 3D printed device. This is a case study successful implementation. The institution was Children's Hospital Boston, implemented 3D printer surgical guides for cleft palate repair in 2019. Approach patient CT scans were converted to 3D models, custom surgical guides directed precise tissue reposition during surgery. Outcomes, operative time reduced by 40%, post-operative complications decreased by 30%, and patient satisfaction score increased to 94%. Long-term speech and feeding outcomes improved significantly compared to conventional techniques. The impact protocol now across 12 affiliated hospitals, treating 200 or more patients annually with measurable improvements in functional recovery and quality of life. As you can see, this is the model that they use to practice about the sutures, about printer before they implement in those patients. As a finalize, I want to talk about technology is the best when it brings people together. The converge of 3D printer and healthcare exemplifies innovation power to transform patients' outcomes and advantage human potential. Thank you so much for your attention.
Thank you so much, Mrs. Claudia, for your very, very interesting presentation. It was indeed very inspiring, especially with the latest advancements. Are there any questions? I open the floor for any questions from your side. I don't see any questions. If you allow me, I would like to ask one question. I have noticed in one of your slides, you were mentioning about the future trends in 3D printing, which serves dentistry. And I would like to ask you, which one of those new technologies or approaches you would think will be most adopted widely and why?
Okay. I think that is the AI assistant 3D modeling because, as I mentioned, we try to save time for those kids, especially I'm part of the nonprofit organization back in my country, in Colombia. And the challenge that we have is about obviously the money to buy the equipments, right? But as I mentioned, here in Boston, Massachusetts, they already implement those procedures with a 3D. And as I mentioned too, this is a long-term since 0 to 10 years old. And this is exhausted for families, for the mom, for everything. And I think that if we can converge the 3D and talking about AI, educate our patients, educate the family, that be a great future introductions for those families that have this kind of situations.
Thank you so much. Thank you so much again for your presentation.
Thank you
I
for
would
the
like
opportunity.
thank you. I would like to invite our next speaker. Our first poster presentation is going to be delivered by Dr. Jesus Mendiolaza, who is a board-certified cardiologist from the United States of America. He will present chest-computed tomography utility and an incidental finding during lung cancer screening as its correlation with myocardial perfusion imaging study in a rural regional setting to assess indirectly coronary artery anatomy and its management. I kindly invite you to start your presentation. The floor is yours, Dr. Jesus.
Good morning. Can you hear me?
Yes, we hear you very well. Will you share your presentation, your poster?
Sure, thank you. Yes,
Thank you.
I go to share. You allow me to. Can you see that?
Um,
Can you see that poster or no?
Not yet. Now yes. Now we see this. Mhm.
You see? Okay, let me just now. Can you see that now?
Yes.
Okay. Thank you very much for having me. I am a board cardiologist and invasive physical cardiologist in the United States. I've been in the field for the past 32 years, but as an interventional for 25. And what I would like to relate to you guys is with respect to uh, one of the advances in cardiovascular imaging when it comes to patients who they have some uh, conditions that may impact their life as well. So to start with, we had a case of a 57-year-old female who presented to my office, uh, basically with complaint of shortness of breath as well as fatigue. This is an individual who we use technology to better assess and to really treat a pathology that was really very complicated. She had a history of newly diagnosed bilateral breast cancer. And with that, I will not go into the intricacies of technicalities of which kind of breast cancer was. 57-year-old female. And so, the fact of the matter is that she was sent to the surgeon. And the surgeon, as part of the protocol process for the surgery, always to order a CAT scan of the chest to be sure that there's nothing underlying as part of the workup process and to elucidate which kind of a surgery will he proceed, mastectomy and so forth, is just part of the process. Incidentally, he found in that computer tomography of the chest a thrombus or a clot in the major vessel, which is the aorta. Is a territory in which is extremely uncommon to find a thrombus or a clot for many aspects, but by physics is 1 in a million. So he relayed to me as an expert in the field, saying, "What do you think that it is?" To me, it's a thrombus. And I took a look at the CT non-dedicated cardio. I will elaborate what is the meaning of dedicated and non-dedicated computer tomography of the heart. And so when I look at the images, to me, it was more like an ulcerated plaque, one of the phenomena that occur for the aging process, cholesterol, and so forth. By physics, as I explained to you, the flow and so forth do not allow those principles of physics to have a thrombus in the ascending aorta. Nevertheless, this is one of the things that I have learned during my tenure as a cardiologist and interventional structuralist. I met with an individual, with a female, get a history, and I scheduled her to corroborate some findings with a technology which is called transesophageal echocardiography. In layman terms, what they do in the operating room, and introduce a probe through the esophagus and go and visualize what you see in here in the most complete manner. This is for the heart, and this is for the aortic valve. But the fact of the matter is that you see, guys, this structure, which is very enhanced, is showing me that she has a clot in the heart. For me, the purpose of doing this test is to see whether or not I was going to visualize not the heart per se, but the ascending aorta, which is of the heart, but my technique will allow me to visualize that quote hypothetical thrombus in the region, which is not expected. As soon as my protocol started, but the protocol is also that as well. Surveil the heart and making sure nothing is there. Well, incidentally, I found this mass lesion that you can see here that is like mimicking like a tumor or a clot in the heart per se, which I was not expecting. One of the things that I related to is to convince myself that the thrombus in that aspect of the aorta, the vessel, was an ulcerated plaque, which is normally. When I found this, I said to myself, I cannot believe them that the lesion that the surgeon referred to me really broke all the physics and laws, and incidentally, I found this. So, what I thought, hypothetically speaking, clinically, because this saved the life of a patient in the approach surgically, clinically, and prognostically, is that it was not a plaque, but it was a thrombus in the most not common area. But also, not only that, when I surveilled her heart, she was filled in the left side and the right side of thrombus all over the place. Needless to say, when I apply now a dedicated computer tomography of the chest of the heart, I totally corroborate that. When I mention the term dedicated computer tomography, it's a technique that far advanced cardiac imaging cardiologists with an expertise and training in computer tomography, which is a bit more sophisticated because general cardiologists and interventional cardiologists will not know radiology. You need to be expert and trained in radiology aspect and to interpret the human anatomy when it comes to the heart. We've been blessed in doing that training, and when I assess these cardiac images, just for you guys to relate to, just to give in layman terms, these arrows and these images that you visualize here, as well as these images in here, shows that these little obscure or dark rims in here and this widening in this area and these sections, they are part of the aorta, which is the major vessels. So this image is an echocardiogram. It's a technique that uses ultrasound, which is a different technique that is using this. The bottom line, not only we corroborate that this lady has thrombus, but sadly to her dismay, she was found with obstructions and clots diffuse from the heart all the way through the aorta, going all the way through her abdomen. So the bottom line is that indeed cardiac tomography did allow us to determine first prognosis, number two, diagnosis, and number three, with combined imaging modalities such as computer tomography and echocardiography, either with radiation, with computer tomography, and in addition to that, with echocardiography using ultrasound wave Dopplers to clearly depict, diagnose, and then install medical therapy. Well, this was a very complicated case. What to do with a 57-year-old female who will go for mastectomy bilateral for her breast cancer. But not only that, now she had a problem, which is multiple clots or thrombus diffuse from the heart all the way from the major vessel, the aorta, the ascending portion, all the way till almost the legs. Why did she develop this? One of the hypotheses is that because she was a smoker and also cancer, for everybody who is unbeknownst to the field of cardio-oncology or oncological cardiology, they are very prone to have clots in or form clots. It just comes with a territory. Clinically speaking, the patient was awake, alert, oriented, vital sign was totally stable. She presented to me basically pretty much with a blood pressure of 120/80. The physical examination with this individual was unremarkable, and the breast cancer was found incidentally in a mammogram. Her laboratory data was not in any way threatening, and her electrocardiogram was flawless. So that's the interesting portion of this case, in which pertains how we, invasive and interventional cardiologists, with using sophisticated cardiac imaging, we can elucidate and diagnose. This individual was very hard. I trained at Stanford University in California, and I spoke with many of my colleagues in terms of what to do with this individual who has diffuse disease how to treat her, because there is no guidelines for such phenomena. Bottom line, I talked to my buddies in Harvard, then John Hopkins, and then people that I trained in Stanford in California, and everybody gave me a different opinion. Surgery, thrombectomy, blood thinners, different approaches from the surgical to medical management. I wrap it up and I tailor to the patient, and in a shared decision making, we decided to treat her with anticoagulation, which is blood thinners, for 6 months. First, get her surgery. God blessing, she went through that, and I managed her just medically. That was a shared decision making because there is no single treatment. There's no single approach that is validated. All of them are experiences. There's no evidence-based medicine in this scenario, and she's doing fairly okay, very well. Cancer-wise is free. She is still for long life with anticoagulation, and thus far, no development of any complications pertaining to those thrombus. Overall, to conclude, just want to elaborate how sophisticated but evidence-based up to date imaging modalities allow us to diagnose, detect, prognosis, and to treat these maladies that could have portend bad outcomes in our patients. Thank you.
Thank you so much, Dr. Mendiolaza, for this great presentation of your poster. I do not see questions, but I would like to ask you one. You mentioned in your presentation about the accuracy of cardiac chest computed tomography. Would you consider other imaging techniques in the future, which maybe are still in their very early stages, but with also innovative approaches when it comes to similar cases in the future?
That is a very useful question, and yes, indeed. I think that in the early stages still, cardiac MRI is right now in the process of developing that. Thus far, the gold standard is computed tomography, and the reason is because it allows us to differentiate, masses in that. Computed tomography uses a different imaging and physics. Cardiac MRI is usually as well good in terms of the vessels, in terms of the aorta, the anatomy. Thus far, the algorithms are not yet accurate to determine basically pretty much those areas of enhancement on the thrombus. But cardiac MRI is getting in there. And the beauty of cardiac MRI is that it gives you a more comprehensive assessment of the vessels, physiology, the heart, the valves, and everything else. And yes, indeed, that's a shortcoming of the MRI as of now. But I believe the next 6 months to a year, it will be there. So yes, thank you.
Thank you so much again for your presentation. And I would like to move to the next speaker, who is Mrs. Yvette Mayer, Unit Manager, Operating Theater, Obstetric OR, Endoscopy and CSSD, who is joining us from the United Arab Emirates. She will present on multiplying potential, the influence of multiplier leadership in driving empowerment, engagement, and quality improvement in healthcare. Please, Mrs. Yvette, the floor is yours.
Hi, good afternoon, Dr. Kat. I'm audible and visible?
Yes.
Okay, I will just go ahead and share.
Please.
Okay. You are able to see?
Yes, we do.
Okay, fine. So, yeah, I'm back again. So, I am Yvette. Just to give you a little overview of myself, I'm in nursing for the last 32 years with a specialization in operating room theater, CSSD, cath lab, endoscopy. I do not have any disclaimer or affiliations And so, rightly, as Dr. Katz said, that this is my topic. I will be speaking on the influence of multiplier leadership in driving empowerment, engagement, and quality improvement. So these are my objectives. I will be going very quickly through traditional leadership models, define multiplier leadership in healthcare, differentiate between multipliers and accidental diminishers, explore the impact on staff empowerment, as well as assess influence on actually staff engagement, as well as link leadership to quality improvement outcomes and apply multiplier practices in clinical settings. So as an introduction, healthcare systems are increasingly challenged by workforce burnout and rising patient complexity, as well as a demand for high quality, safe care. And that is why it's so important that we have the correct leadership. And leadership is a key dominant of organizational performance and outcome and patient outcomes, according to Cummings et al. In 2018. Now, traditional leadership models are often based on hierarchical. It limits the staff autonomy. It reduces the staff engagement to suboptimal utilization of the workforce capability. And we will delve later on into that as well, and reduce innovation in quality improvement. The traditional type of leadership, and especially in nursing, as I am a nurse, and maybe so in healthcare as well, is we are using autocratic leadership style. And this kind of leadership style doesn't really have that much of a space, except for where it's emergency, where you have relatively freshly graduated staff, because this kind of leadership takes strong control and it doesn't take really input from staff. The leader is actually the one taking the show here. In a democratic leadership style, it involves a team in the decision making, and it encourages collaboration and shared responsibility. This improves staff satisfaction and engagement. Then we also have laissez-faire leadership, which this you actually can use when you have a highly matured team, because it takes a minimal supervision, and your staff then have high autonomy and a lack of direction if not well managed. And this is usually where the pitfalls are, is that there is no direction if the leader is not strict and have this kind of laissez-faire attitude. Transactional leadership focuses on structure, rules, and performance, on rewards and penalties as such, and it ensures compliance with policies. Then we go to one that is more mature, I would say, transformational leadership, which inspires and motivates staff. It focuses on the vision, on change and innovation, as well as strong impact on culture and engagement, and it drives quality improvement and patient safety innovations as well, and initiatives. The bureaucratic leadership style is very strict to it's the highway or the byway. So you either follow the policies and the procedures or you leave it. It ensures consistency and safety. It's got limited flexibility. And this kind of leadership you use in infection control, medication administration, as well as regulatory compliance, because you cannot allow anything other than the correct thing to be done in this kind of leadership. Now, leaders who amplify intelligence and capability and ownership of their teams actually qualifies as the one that I would like to talk about today. So in 2010, Liz Wiseman developed the multiplier leadership. And this is actually something that I only came to know about recently. And I would think that this is the way to go within nursing and in healthcare. There are two types of leadership within what Liz is describing, and one is a multiplier. It takes talent of people, it expands their capabilities. This kind of a leader is a talent magnet. It's liberating to the staff that works with this type of leader. They allow also to challenge and be challenged. They are good debate makers, and they invest in their team or in the people that work with him. On the other hand, you have accidental diminishers. Now, I think another word for diminishers would be micromanagers. But in this case, actually, it's not so much driven or the purpose to diminish people. However, it restricts the thinking and contribution as well as the innovation of the team. The leader is the one who's driving everything. It's a tyrant kind of attitude. I am the one, I am the know-it-all, I am the decision maker, and like I said, I am the micromanager. Accidental diminishes in healthcare leadership, they actually have intention, but unintentionally, sometimes they limit the capability of their team. And this is according to Liz Wiseman in 2010. They also reduce the ownership, the engagement of their team, the thinking cap, the critical thinking of their team, they diminish. And this is not good if you want to grow and have a good team. The impact of accidental diminishing leadership style in healthcare, and there's a lot, but the ones that stand out for me, it compromises patient care and safety, as well as it increases medical errors. There is no or less communication because people are scared to speak up. This kind of leadership style also, toxic organizational culture is rife in this kind of leadership style. Staff are not able to speak up. It's a culture of silence where employees are afraid to report errors and voice out their concerns. Fear of retribution, that they will be judged. It's poor resource managers, if you get down to it. It creates high burnout, turnover, stress for the staff, and like I said, less engagement, and staff is not interested to be interactive. They would rather come, do their duty, and go home. So why leaders become accidental diminishers? Now, it's important, like I've been saying in the morning, sometimes it's a generational thing because people who tend to have more expertise and high years in a certain job, they tend to have this seniority complex, and that creates and makes them actually sometimes accidental diminishers. So the desire is to protect the team, but in doing so, they are not giving the team a chance actually to interact and to, be vocal and to participate and to be involved in the safety outcomes of their patient. And they have this habit of fixing everything. So what is multiplier leadership? Well, multiplier leadership is where the leaders amplify the intelligence, the capability, the contribution of individuals, the team, and enable them to perform beyond expected levels. You allow people to grow into their own. You are there to guide and to direct, but you do not do the job for them. It's not about being the smartest person in the room. It's about creating a system where everybody contributes their best thinking. They put their thinking hats on. And in healthcare, this directly translates into better decisions, safer patients, and stronger teams. The core disciplines of multipliers, according to Wiseman, is these people are talent magnets. They attract people. They utilize the talent. There might be one point that stands out within a staff member, and they will utilize that strong point to build around and to multiply what the staff member has to give. They liberate and they create an atmosphere where staff feels safe to speak up, a psychological safety as well. They set high expectations, but at the same token, they are also there to give direction. Like I said, they encourage thinking and they build ownership and accountability. Now, comparative perspective with regards to traditional leadership and multiplier leadership is traditional leadership is I'm giving the direction. It's a control-based leadership. It's a leader in dependency from the team, and it's compliant focus. Whereas multiplier leadership, it's a trust-based. You need to have a high level of trust in your team, in their capabilities, and in your decisions as a multiplier. It is team-driven and it is empowering. Multiplying leadership aligns with transformational leadership. And I think this is the one that gets the closest to multiplier leadership is transformational leadership. It's the empowerment, like I said, the psychological safety. It integrates the leadership and the organizational behavior and quality science. It reduces mortality because if a team is safe to speak up, if that environment is safe for them to speak up, they will point out more things that can be corrected earlier until it reaches, the patient. It is a higher staff satisfaction. And while direct empirical evidence on multiplier leadership in healthcare remains emerging, its principles aligns with established evidence on transformational and empowering leadership, which are strongly associated with improved patient and workforce outcomes. The empowerment in healthcare, when you have a multiplier leader, is the leader pushes the team to a point where they can make a decision. There is trust in the nurse, the technician, the coordinator, and it reduces hierarchical barriers. And this is what we need to aim to if you would like to be a multiplying leader and to empower our teams, as well as drive staff engagement. And this is so important that staff feels heard, valued, trusted. And this is what a multiplier does. It creates a high psychological ownership, increased job satisfaction, it reduces burnout and engages team, and with the result, better patient outcomes. On quality improvement, if a team is feeling free to speak up, they have this inherent feeling of, there will be no retribution, I can report. It is a just culture in the true sense, and that will improve quality within the workplace. As a multiplier, you promote speaking up cultures, you create a safe culture. Like I said, there is earlier detection rate because of the openness to speak up, as well as open communication, which directly reduces adverse events in the workplace. So, how do you apply these practices in a clinical setting? You have to empower decision-making at the point of care, where your team owns the power to make a decision. However, not to the detriment or the harm of the patient. You use questioning instead of giving answers. Why, when, how, who. Instead of providing the answers, you let the team use their critical thinking and diagnostic reasoning. You delegate the ownership of outcomes. You create a safe environment. You stretch the team capabilities through challenging them, but all the time make them aware that you are there as a safety net. You promote disciplinary collaboration. You recognize and utilize individual strengths. The barriers are hierarchical culture, the fear of losing control, and this is for the leader itself. Why people struggle to become multiplying leaders? It's because it's inherently that I have to be the one in control. It also is time pressure in clinical environments that prevents a person from stepping into the next level. And it's a lack of leadership training, either within the workplace or for the person themselves to invest in themselves in leadership training. Organization that adapts multiplier leaderships, they see less staff turnover, high engagement scores, quality metrics and compliance, and an improvement in innovation and problem solving. The greatest risk in leadership is not bad intent, but good intent applied in a wrong way. Multiplier leadership is not about doing more. It's about unlocking the potential more from the people that they already have. Awareness of accidental diminishing is the first step towards becoming a multiplier leader. Thank you very much.
Thank you so much for this excellent presentation. I would like to ask Mrs. Yvette one question. When it comes to the leadership you mentioned, 58, almost 60% of people have very high issues with self-awareness. So how can a leader, potential person in healthcare system, kind of provide some kind of diagnostics and verify that they need a training? So if you would like to give a short reply to that.
Sorry, I was on mute. The most important thing is that you need to assess yourself. And this is where the most difficult part is that people, they're either too scared to assess themselves and to see honestly where they are within their journey of self-awareness. Because self-awareness takes a high level of emotional intelligence. And if you don't have at least a little bit of emotional intelligence, you will struggle to understand where you are in your journey of self-awareness. Because if you are critically aware of yourself, you can then lead others. You lead within your organization. And that is what is important. There are so many, and the problem also is that people are, I think in general, people are not really wanting to invest in themselves. And you need to invest in yourself if you want to create this kind of a level of self-awareness, either by reading books, by taking courses, studying further. Even be brave enough and ask people, do a 360 and ask, the questions, what type of a leader am I? That's only if you're brave enough.
Fantastic. Thank you so much for this reply.
Thank you very much.
As we're running a little bit behind the schedule, I would like to move forward to the next speaker and invite Ms. Amanya Amin, who will present about pregnancy and oral health, the critical window for prevention and early intervention. Mrs. Imaniak, the floor is yours.
Hi there. Unfortunately, my camera doesn't seem to be working, but I can still share my slides, so I'll just share them with the screen. Let me know if you can see them, please. Just give me a second. Okay, are you able to see that?
We are able to see your presentation. Thank you so much.
Brilliant. So good afternoon, everyone. My name is Imania Amin. I'm a registered dental hygienist from the United Kingdom, and it's a pleasure to be speaking with you all today. So over the next 15 minutes, I would like us to look at pregnancy, not as a high-risk condition, but as a critical opportunity where preventive oral health care and early intervention can have lasting benefits for both the mother and the child. So let's start by asking, why does pregnancy matter so much when we talk about oral health? So pregnancy is a unique physiological state where hormonal, immunological, and behavioral changes occur simultaneously. The oral cavity is one of the first places where these changes become clinically evident. So these systemic adaptations influence gingival vascularity, immune response, and salivary composition, increasing susceptibility to plaque-induced disease. Now, the World Health Organization recognizes oral health as an integral part of general health, particularly in vulnerable populations, so such as pregnant women. And what makes this period especially important is that patients are often more engaged with healthcare, and they're going to the hospital regularly, seeing their midwives, coming in to see dental professionals. So it makes it a key window for prevention and behavior change. To understand this increased susceptibility, then we first need to look at the underlying hormonal changes. So during pregnancy, levels of estrogen and progesterone rise significantly. Now, with estrogen, it increases gingival vascularity and capillary fragility, which leads to edema, a greater tendency to bleed, so we'll see more bleeding from the gums. On the other hand, with progesterone, it alters the host immune response, so it's reducing neutrophil function and it's increasing inflammatory mediators such as prostaglandins. We also see microbial shifts, so there's increased levels of gram-negative bacteria, such as Prevotella intermedia, which can utilize these hormones as growth factors. So clinically, what we're seeing is not necessarily more plaque, but it's a significantly exaggerated inflammatory response to it. And this exaggerated response is what underpins one of the most common conditions that we see during pregnancy, and that's pregnancy gingivitis. So this condition affects up to 60 to 75% of pregnant women, and it typically peaks in the second and third trimesters of pregnancy. It will present with bleeding, erythema, edema, and it's often disproportionate to the amount of plaque that's present. Now, this is due to an amplified inflammatory response. So you've got mediators such as your interleukin-1 and your TNF alpha playing a role in this. So for patients with pre-existing periodontal disease, these systemic changes can actually accelerate the progression if it's not managed effectively at home. Now, what you can see in the photo on the slide is a pyogenic granuloma, sometimes referred to as a pregnancy epulis, and it's basically a localized, exaggerated inflammatory hyperplastic lesion, which is associated mainly with plaque, and it can occur mainly on the gingiva. So although it's benign, it can bleed easily, it may cause some discomfort. So the management focuses on plaque control, patient reassurance, and monitoring, as many pyogenic granulomas can resolve postpartum. Of course, gingival inflammation isn't the only challenge. Pregnancy can also affect caries and erosion risk, which brings me on to the next slide. If you just give me a second. Okay, so dietary changes then, including increased snacking and cravings for fermentable carbohydrates, increase caries risk by prolonging periods of low plaque pH. You can see this on the diagram, which is the Stephan's curve. So the salivary changes in some patients may reduce buffering capacity between the periods of remineralization and demineralization. So vomiting, acid reflux expose the teeth to gastric acid with a pH of around 1 to 2, which can rapidly demineralize the enamel, which further contributes to erosion of the different surfaces of the teeth. Now, these are often dismissed as temporary symptoms, but the impact on the enamel is permanent. And the Delivering Better Oral Health Toolkit, which is something that we follow here in the United Kingdom, it emphasizes on reducing sugar frequency, promoting the use of fluoride to kind of mitigate these risks. But I will discuss this later on in the presentation. Moving forward then, another factor that can further increase oral health risk during pregnancy is gestational diabetes. Now, gestational diabetes is associated with increased systemic inflammation and impaired immune function, which may develop in the second or third trimester. It is something that can also affect between 5 to 15% of women worldwide. This can lead to heightened periodontal inflammation, as you can see on the image in the slide, and delayed healing. Now, xerostomia, which is also known as dry mouth, that's something that can also be present, furthermore increasing a caries risk. So from a dental hygienist perspective, this reinforces to us the need for early intervention and enhanced plaque control and preventative strategies. So now that we've sort of looked at the local oral changes, why does this matter beyond the mouth? So periodontal disease contributes to systemic dissemination of inflammatory mediators such as prostaglandin E2 and C-reactive protein. Now, these have been implicated in pathways associated with preterm labor. So while the causation remains complex, associations between periodontal disease and adverse pregnancy outcomes such as preterm birth and low birth weight have been reported. Now, the World Health Organization highlights the importance of reducing chronic inflammation and infection as part of maternal health strategies. This often leads to an important clinical question, which is how safe is dental care during pregnancy? So preventative dental care, which is including your routine scaling, polishing, oral hygiene instruction, anything like fillings, crowns, is generally safe throughout pregnancy. The second trimester is often the most comfortable, but delaying care is not evidence-based. So dental x-rays may be delayed as a precaution. However, it's still considered safe with the correct strategies in place. Additionally, for patient comfort, it's recommended to adjust the dental chair to avoid any supine hypertension, which is a condition that can occur in the third trimester of pregnancy when laying too far back can cause dizziness, nausea, and low blood pressure. Now, guidance from the National Institute for Health and Care Excellence supports maintaining routine oral health care during pregnancy. In fact, avoiding any sort of dental care during pregnancy may actually increase risk due to unmanaged infection, which directly brings us on to the role that we play as hygienists. Now, dental hygienists play a central role in taking a holistic approach. So we like to sort of take an approach where we're looking at the whole body. It's not just the mouth. The mouth is the gateway to the body, essentially. So we identify risk factors such as poor plaque control, dietary habits, and systemic conditions, while still prioritizing safe delivery of care for our patients. So we begin by risk assessing our patients to ensure that we can deliver tailored preventative care. This includes checking their medical history, their social history, if the patient has any systemic conditions, any allergies, any medications that they might be taking, as well as their smoking habits if they are smoking, and alcohol intake. Now, for pregnant patients, if they are smokers, it's important to inform them that smoking increases the risk of gum disease due to an impaired immune response, as well as increasing the risk of early childhood caries for the baby. If the patient is already showing signs of pregnancy gingivitis and their gums are bleeding, their gums are inflamed, then smoking will exacerbate this. Now, for each patient, tailored preventative treatment plans include professional mechanical plaque removal. So that's essentially, in simple terms, cleaning around the gums, and root surface debridement, which is a bit of a deeper cleaning if there's any hard calculus bacteria that's below the gum line, closer to the root. And we tend to do that when it's needed for the patient. Now, local anesthesia may also be an option, more for patient comfort. However, it's important to avoid prilocaine with velipressin, as this is contraindicated, so it can actually cause uterine contractions, which a lot of the time in pregnant patients we tend to opt for your lidocaine. It's a little bit more safer to use, essentially. Now, for patients who are high caries risk, fluoride application is beneficial. So oral hygiene instruction is not only supporting behavior change, but it ensures that the patients are receiving the correct education regarding their oral health. And behavioural change techniques are particularly effective during pregnancy due to that increased motivation from the patient. Like I mentioned earlier, they're a bit more focused on their general health. They're visiting their midwife regularly, going to the hospital, having their checkups, etc. So our role as dental hygienists isn't just clinical, it's preventative, behavioural, and educational. So what does this evidence-based prevention actually look like in practice? Okay, just give me a second. Right. So according to the Delivering Better Oral Health Toolkit, which I mentioned earlier, these are the following points that should be reiterated to your patients. So this includes brushing twice a day with an electric toothbrush. Now, my personal favorites are the Oral-B IO and the Philips Sonic Air. Using a 1,450 parts per million fluoride toothpaste is also recommended. Now, for patients who are high caries risk, a Durafat 5000 may be prescribed by a dentist for the patient to use. Now, the higher level of fluoride content enhances remineralization by forming fluorapatite, which is more resistant to acid dissolution. So your patients who might be having quite a lot of morning sickness, acid reflux, they're better off using something like the Durafat 5000. Now, when it comes to interdental cleaning, that's essential. Brushing alone only cleans 60% of your mouth. That 40% that's being left without interdental cleaning is essentially you're leaving that bacteria behind. So interdental brushes such as your floss tape, even a Waterpik water flosser will help to remove that biofilm and food debris, which further contributes to your gingival inflammation. Now, additionally, tongue cleaning is something that we recommend quite a lot. It helps to remove bacterial buildup on the tongue, food debris, dead cells. So benefits include treating halitosis, preventing tooth decay, and gum disease. Now, it's important to reassure your patients that bleeding should be explained as a sign to continue and improve interdental cleaning, not to stop. We find that many patients will start to clean between their teeth and they notice bleeding from their gums, and it kind of puts them off a little bit. But if you just sort of push through with your patient and motivate them to carry on, that's something that will benefit them in a massive way. So now let's look at pregnancy specific oral hygiene instructions. So for patients with morning sickness or acid reflux, brushing should be delayed to avoid abrasion of the softened enamel. So it's also recommended for patients to use a small headed toothbrush, sometimes with a larger headed toothbrush, especially with your manual toothbrushes. If the patient has a gag reflex and they're already feeling quite nauseous, it can trigger off a bit more morning sickness. So we always recommend a smaller headed toothbrush, brush at a different time of day. So give a little bit of time after the patient's vomited rather than just brushing straight away. So in that sense, we tend to recommend rinsing with water or a fluoride mouthwash instead, which helps to neutralize acid and restore pH. And then after they've used a mouthwash or a water rinse, they can then decide to brush sometime later in the day. Now, reducing the frequency of free sugar intake is key here. Repeated exposure of sugar prolongs the low pH periods in the mouth. So the Delivering Better Oral Health Toolkit also emphasizes this approach rather than totally restricting your patients from snacking or eating certain things that they're craving. So oral hygiene instructions should be adapted to the patient's symptoms and lifestyle, as this increases their compliance. Every pregnant patient that walks through the door into your surgery will be presenting with different symptoms. So what you want to do essentially is get them on board, kind of tailor your instructions to them so that they can be a little bit more motivated and continue with that. And most importantly, the impact of these interventions extends beyond pregnancy itself. So maternal oral health behaviours significantly influence early childhood oral health. Now, mothers are often the primary transmitters of karyogenic bacteria, so particularly your Streptococcus mutans, which is strongly associated with early childhood caries. Now, this transmission can occur through saliva sharing behaviours, so such as kissing, sharing utensils, meaning that if the mother has poor oral health, this is then increasing the child's risk from an early stage. Now, your maternal behaviours also shape the child's long-term habits, so including their brushing routines, dietary patterns, and their attitudes towards dental care, which is often learned directly from the mother. And the World Health Organization highlights early prevention as key to reducing oral disease globally, reinforcing the importance of targeting maternal oral health to improve outcomes for children. Now, just a couple of key take-home messages for you also to summarize. As I mentioned earlier, pregnancy significantly alters the oral microbiome, so it increases susceptibility to gingival inflammation, periodontal disease, caries, and erosive tooth wear. Now, emphasis on optimal oral health is necessary as there may be links between poor oral health and adverse pregnancy outcomes, so like your low birth weight, preterm labor. Preventative oral health care during pregnancy is safe, evidence-based, and essential. Now, dental hygienists are central to managing pregnant patients through early risk assessment, tailored preventive care, and effective education. So by supporting maternal oral health, we also contributing to improved long-term oral health outcomes for the next generation. So before we wrap up, I'd love to connect with you all. So please feel free to either scan my LinkedIn or follow my Instagram. This is the easiest way to reach me for any questions, collaborations, networking opportunities. I'm always happy to continue the conversation and share resources on pregnancy and oral health. So thank you for your attention, and I hope you found the session informative and insightful.
Thank you so much for this very insightful session indeed. I would just like to maybe bring one question.
Of course, yeah.
So for, let's say, any advice for a woman who is pregnant and would like to improve her state of her teeth, what would be the measures which she can take before? Because knowing that she would like to get pregnant, many women actually are in intense planning, and during. If you would kind of resume this in a couple of sentences.
Yes, of course. So I think for patients, especially if they're planning pregnancy with their partner, I would definitely recommend try to visit your dentist, your dental hygienist on a very regular basis. The earlier that you come in and see us, the earlier we can diagnose anything and try and stabilize things for you, especially with your gum health. So if the patient has said that she's planning for a baby, but she comes in and her gums are bleeding, they're very sore, her oral health isn't great. In my head, that's a light bulb. Okay, let's try and manage the oral health now, make sure the gums are looking healthier. And what we tend to do is we tend to get you in a lot sooner. So where you're presenting with poor oral health, we won't tell you to come back a year later. We'll say, come back in 3 months' time. Let's reassess and see how your gum health is looking. If gum health is improved, it's going to improve the general health as well. So it's like I mentioned at the start, your mouth is the gateway to the rest of your body. If you can keep your mouth nice and healthy, nice and clean, your general health will be just as good. So yeah, I'd say for patients who definitely are thinking of getting pregnant, just make sure you're seeing us firsthand. Patients who are pregnant as well, just make sure you're seeing us regularly throughout your pregnancy. So within the 9 months, I personally, for pregnant patients that I have seen, they come and see me at least 3 times within that 9-month duration, so we can keep an eye on things for them.
Perfect. Thank you so much again for
You're welcome. Thank you so much.
Forward to the next poster presenter, Dr. Rukhsana Fatima, specializing in geriatric dentistry from the United Arab Emirates. And Dr. Rukhsana will present active aging and healthy living. Please kindly welcome Rukhsana.
Good afternoon. Can you hear me? Am I audible?
We can hear you. We cannot see your presentation yet.
See me now?
Okay.
Yeah, okay. I'll share my presentation. Just give me a sec.
You have 15 minutes.
Yeah, sure.
Thank you so much.
Sorry. Can you see my presentation?
Yes, we can. Thank you so much.
Yeah, okay. So good afternoon, one and all, once again. My name is Dr. Rukhsana Fatima, and I'm a public health dentist. Today, I'm here to present my poster on active aging and healthy living in older adults. So, with a rapidly increasing global elderly population, maintaining oral health has become an essential component of healthy aging. According to World Health Organization, active aging aims to optimize opportunities for health, participation, and security to improve quality of life as people age. Oral health plays a significant role in overall health, nutrition, and social well-being in older adults. The field of geriatric dentistry focuses on the prevention and management of oral health problems in the elderly population through preventive care, treatment planning, and improving access to dental services. Poor oral health can lead to difficulties in chewing, speech problems, and reduced confidence, ultimately affecting an individual's physical and psychological well being. According to the World Health Organization Active Aging Framework, 3 pillars optimize quality of life as people age. They are health, participation, security. Health, focusing on physical and mental well being to minimize the burden of chronic diseases. Participation, encouraging continued involvement in social, economic, cultural, and civic affairs, even for those who are retired or ill. And security, ensuring social, financial, and physical protection for older adults who can no longer support themselves. As you all can see, the poster displays the determinants of active aging and the challenges addressed by aging population. So to begin with, the key factors of health and social determinant are disease prevention, primary care, and long-term care. The challenges addressed here are rising healthcare costs and the strain of non-communicable diseases. The key factors of behavioral determinants are physical activity, healthy diet, and avoiding tobacco and alcohol, whereas the challenges addressed are premature functional decline and loss of independence. The key factors of economic determinants are income security, social protection, and work participation, whereas the challenges addressed are economic dependency and potential bankruptcy of pension systems. Key factors of social and environmental determinants are social support, lifelong learning, and age friendly cities, whereas the challenges addressed are social isolation, ageism, and inadequate urban infrastructure. Last but not the least is key factors of personal and cultural determinants are biology, genetics, and cultural tradition, whereas The challenges addressed here are disparities based on gender, ethnicity, or socioeconomic status. As you all know, mouth is a mirror of the body in which all systemic disease will directly reflect in the oral cavity. For example, systemic disease such as diabetes mellitus and cardiovascular disease, which are closely linked to oral health conditions like periodontal disease. In addition, many elderly individuals experience xerostomia or dry mouth due to medication, which increases the risk of dental caries and oral infection. Other challenges include limited mobility, reduced access to dental care, financial constraints, and lack of awareness about preventive oral health practices. To support active aging, it is important to focus on preventive strategies such as regular dental checkup, early diagnosis of oral disease, and patient education on oral hygiene practices. Interdisciplinary collaboration between dental professionals, physicians, and caregivers is also essential. Additionally, advances in prosthodontics and digital dentistry can improve treatment outcomes and enhance the quality of life for older adults. In conclusion, maintaining oral health is a key factor in promoting active aging and healthy living. Addressing the challenges faced by older adults through preventive care, awareness, and integrated healthcare approaches can significantly improve their overall quality of life. The public health significance of active aging and healthy living in geriatric dentistry lies in its ability to delay frailty, reduce the burden of chronic systemic disease, and improve the functional capacity of the aging global population. As a part of United Nations Decade of Healthy Aging 2021 to 2030, integrated oral health into general primary care is a critical strategy for achieving universal health coverage and sustainable aging. Thank you very much for your patient listening. Have a nice day.
Thank you very much for this poster presentation. As we're running a little bit behind the schedule, I will move ahead straight away to the next presenter, who is Dr. Jesus Mendiolaza. Dr. Jesus.
I'm here. Thank you.
Thank you so much.
Allow me to share my presentation, Dr. Let me know if you can see, please, kindly.
Yes, we can see this. Yes, perfect. Thank you so much.
Well, good morning again. My name is Dr. Mendiolaza. I am a cardiologist interventional in the United States. I am in the state of Florida, in the Orlando area, but I've been I have my global concierge practice throughout the world, and I have been in Asia and many places in the world. Nevertheless, I want to thank you for the organizers and allow me to present this case as well. And the previous presenter was compelling, and I was very much impressed with an impressive study in terms of the public health, oral hygienist, oral periodontal disease, because there's a close relationship with cardiovascular issues, and that was quite impressive. Moving along the lines of using this imaging modality now, we present a case of a 57-year-old female with a history. This is the patient. I apologize. Of a patient with is a case 50-year-old female, and here allow me to share with you a little bit. I apologize for a case. It's a 57-year-old male with a history of smoking history as well as shortness of breath. African American male with hypertension, lipidemia, and poor control blood pressure. He presented into the emergency room with complaint of such. There was one of the protocols in the United States is just trying to elucidate any kind of cardiovascular matter, such as pulmonary embolism. what it is an entity that is the formation of blood clots in the lungs, which is part of the things that we need to further elucidate. Interestingly, as part of the protocol, the patient went from the ED in the United States. Usually, we have CAT scanners in every single medical center or establishment. Bottom line, as you can see in the process of obtaining the CAT scan of the chest to make sure that he did not have any blood clots in the pulmonary arteries, which are the major vessels in which those blood clots form and tend to perhaps portend short breath, the difficulty breathing during exertion. He has his risk factors such as high blood pressure, cholesterol, poor control, blood pressure, and also smoking history. There is a pretest probability in which emergency physicians in the United States quickly and accurately determine whether or not using clinical algorithms that pretest probability for blood clots. And if so, medical therapy has to be initiated immediately to avoid bad outcomes. What I'm implying to is the use of blood thinners intravenously and then switch to orally thereafter 24 or 40 hours. With that being said, the image that you visualizing here is for the computer tomography of the lungs, but also now is depicting the heart in here. And as you can see, this is a chamber of the heart, which is called the left ventricle, and this is called the left atrium, which are part of the process of the anatomy of the heart. As you can see here in this image, which is obscure, what we call radiotechnically speaking, in the MRI, this is a different modality. MRI doesn't use radiation. And as an expert, now we switch the gears from what I presented before with a computer tomography, in which we use nuclear medicine, but also more physics and radiation techniques. This is a non-radiation modality. It's better off usually pretty much resonance magnetization, different to the physics. So we're switching the gears to a different modality. Made a long story short, we have several criteria or parameters, but visualizing here this tremendous bulging that is not normal. Even for the unbeknown, somebody will say, well, what is this entity that we're visualizing here? This is for the tissue of the heart. The heart is this tissue that you see here thing is called the myocardium, or the wall of the heart. But in this section of this man is bulging tremendously, as you guys can visualize in this structure. So the case was presented to me as per the MRI of the heart that I did ask for this patient. The reason being is because prior to obtaining this test, this patient, when keeping in the clinic, we did the CAT scan, shows a lot non-specific. We did an ultrasound of the heart echocardiogram, which shows me this entity, which I will present to you. And then I went to further, pretty much rely and diagnose in a better fashion this problem. This enhancement in the cardiac MRI after those previous testing is a rare but a common, if I may say, congenital problem. Is called hypertrophic obstructive cardiomyopathy. All in all, is thickening of the heart that can be presented early on in the age process or later on as well. Tend to occur in a dominant fashion. Is pretty much common in a 1 to 250 individuals who they have such a phenomenon in the genes that encode the tissue of the heart. And in the United States, it's one of the most common reasons for sudden cardiac death in young athletes, if it's not the most prevalent. And the reason is because it presents in different ways to the point that when this grows too fast, it obstructs the flow of the heart to the whole system. In doing so, there's a stealing flow of the blood throughout the whole body. So more so, that will occur in nourishing as well the heart through those tiny, tiny vessels that we call coronary arteries. I don't know if you're familiar with that, but when somebody has a heart attack or some sort, these vessels are occluded and patients demise or patients have a heart attack. Well, in young individuals, this chamber, which is called the left ventricle, decreases. Cardiac MRI allow us to visualize this phenomena, allow us to see clearly how this can grow and produce obstruction of the flow through the whole system. In addition, this is one view, and this is the second view, which is called the short axis. You can see here, this is the anterior aspect of our heart, body, and this is the posterior aspect where the vertebra and the spine is. This structure is the heart, and this is the chamber, and this is the right chamber. Both are heart. Here we demonstrate that this patient has this malady, which is the disease that I'm implying to. Not treated, these men will really not have good outcomes, including perhaps demise or some sort. So cardiac MRIs allow us to truly assess, number one, diagnose, number two, number three, confirm, and number four, decide which medical therapy, from conservative management to the most advantageous surgical approaches, depending upon the stage. Yes, just to visualize, this individual went through the surveillance process. One of the things that is concerning in these patients who is like this gentleman, presented with shortness of breath and so forth, is to determine whether or not this obliteration, this tissue is growing so much that is obstructing the flow coming from this chamber through the whole body. This is the aorta, which is the major vessel coming on. So when that occurs, these patients will have passing out or syncopal episodes, chest pain, or worst case scenario, sudden cardiac death due to lethal arrhythmias. So recognition and prompt therapy is imperative because patients die at the ages of 20, 21 if we are not aggressive and quicker. Modalities, as I expressed to you, from medical therapy orally, which entails the blockers, first step of the line, medication type. But when this entity, this part of the tissue goes too much that you can see in some cases, you also have to decrease the size.
Thank you so much for this poster. I understood well. We cannot hear you, Dr. Mendiolaza.
Can you hear me now?
Yes, I do. Yes.
Okay. So just to wrap it up, in a sense, in a sense, uh, overall, I don't know if you can see my screen or not, but in a sense, this individual went through a surgical procedure in which what we did was basically pretty much subjected to decrease that area of the heart, which was thick, in order to save his life, and he's doing much better after that. So, all in all, cardiac MRI is a tool that allows us to visualize patients who they have this malady and which is congenital and which could be, life-threatening if not recognized, approach and deal in a very fast and expeditious manner, because in this case, time is of an essence. Thank you.
Thank you so much. I would love you to go ahead to the third poster, if you would agree.
Sure, absolutely.
Thank you so much.
Perfect. Let me go ahead. Can you see my...
Yes, we could. Now, not anymore.
Hold on. Something is transpiring here that I don't understand what's happening. Can you see now?
Yes, we do. Thank you so much. Please go ahead.
Okay. Allow me to present this case of a case of a patient who we use uh, chest complete tomography as part of the screening process of in a rural setting for lung cancer. In the United States, aggressively, we are doing now a screening cancer for patients who they have history of smoking as part of the prevention according to the CMS or Center for Medicare and so forth. So I got an introduction of a 70-year-old male who presented with a history of hypertension, obesity, heavy smoker with a 30-year pack history. That means that he's been smoking at least one pack per day for the past 35 years. He presented to his primary care physician for initial evaluation as part of his routine physical examination. In essence, blood pressure at the time presentation was 120/90 with a pulse of 70 beats per minute. He was mild, short of breath. He has what is called expiratory wheezing on his physical exam, but otherwise, the remaining of the examination was totally unremarkable in terms of physical examination, blood pressure, pretty much GI, heart, vascular, and so forth. The primary care, as per the screening tool and workup process, smoking, 72-year-old male, the guidelines clearly recommend do a CAT scan of the chest as a screening to make sure no occult lung cancer or pulmonary nodules. Well, as you can see in this image, which was just basically the lungs, part of the imaging modality is that also we tend to visualize what is called the coronary arteries. Now, granted, this is an individual who presented to the office of the primary care with the diagnosis of just screening blood pressure, mild short breath, but a heavy smoker, and he underwent this testing to rule out pulmonary and lung cancer as part of the screening process and as well as part of the guidelines, just like the beautiful in England, the National Health Services and so forth, and in many countries in the world, they have different protocols for prevention. So when they refer this to me, in the United States, the radiologists report no lung cancer and so forth, but he's obligated also to report just to describe if see any calcifications or any problems in the remaining of the tissues and organs which are being scanned. So he mentioned presence of coronary artery calcifications. What that means, as I expressed prior to my presentation as an interventional individual cardiologist in the United States, he mentioned severe coronary artery calcifications, meaning that the vessels that supply blood flow to the heart, when they get obstructed and we have heart attacks, that is what concerns the radiologist, and it's just simple that. The report came to the primary care and he referred a case to me. As per that, please figure out what that means, calcifications. I took out the film, and as you can see, these in terms of cardiovascular, these are the coronary arteries in a very impressive fashion. But again, this was a test which was simple, non-specific cardiac-wise, because when we do cardiac, we use a different technique that is not part of this presentation. But just on a plain old fashioned, these are vessels, and this wide enhancement shows how severe calcify in this heavy smoker individual, completely heart-wise asymptomatic, no chest pain, no shortness of breath, no fatigue malaise, or any kind of like mimicking or reflecting heart disease. So this was found incidentally. So when he came to me and I assessed the patient, of course, initial evaluation really was comparable with what the primary care presented the case. But to me, the classifications were so heavy. Now, this does not mean this classification is within the lumen of the coronary arteries, but with the history and the electrocardiogram was what was compelling for me to decide the next imaging modality. So I switched the gears from one imaging to a different modality. As an expert in all imaging, this individual, his electrocardiogram was abnormal. When it was showing me early signs of blockages on the vessels. That's why I did a procedure which is called a nuclear using single photon emission computed tomography or SPECT to determine whether or not these calcifications were obstructing the vessel and just not merely calcium within the lumen or the vessel or around. In this imaging that you see here, this is using now nuclear photon technology from computed tomography using atomic energy. We went to nuclear imaging using photon and electrons and the photon classification. Bottom line, this is anatomically, it tells me obstruction anatomy. This tells me physiology. If there's flow obstruction, one complement each other. And so this image that you see here is the heart completely. Normally, in a normal individual, you will not see this enhancement here. And you can see this is the heart upon rest. And that's what we call a stress test. We use different agents or the treadmill stress test to accelerate the heart, to put quote at stress. And when there's a stress, meaning rapid heart rate and so forth, if there's a blockage, then the area or the vessel that is suspected will now increase the blood flow, giving us this image of what is called enhancement or obstruction. The patient became short breath during the test. He became having some chest discomfort for the first time. Granted, he came to the office with a screening and he did not have ever any heart problem. This was an incidental finding. This shows obstruction with a mild discomfort during the testing that we did. The bottom line happened. This is showing me that indeed he did have incidentally a severe obstruction in the territory on one of the major vessels, which is called the Widowmaker in the heart. Widowmaker, why? Because it's the left anterior descending that supply blood to the heart up to 70%. So when this vessel gets blocked, a lot of patients tend to demise as the first sign of disease. Granted, the gentleman walking with no heart symptoms, and then it's showing me incidentally and coincidentally why heart disease is the number one killer in the world and number killer in the United States, with almost like 25 more prevalency than all diseases combined together, including breast, lung cancer, and so forth. 25 more times. In the United States, we cardiologists and all over the world are the busiest individual for many aspects within the part of the process, diet, exercise. Nevertheless, upon this, as an interventional, I proceed to take this patient to the cardiac catheterization laboratory, where it is I go with a technique through his right arm, and go to his heart and inject contrast dye in which I will depict each vessel of the coronary anatomy, the right side, the left side, and the widowmaker, which is called the left anterior descending. In here, I'm introducing my guide wire, and all of this we do with a patient awake, sedated, and the heart beating. No more bypass surgery, no more opening the chest. We do that in a non-invasive manner. And I noticed in my process that he did have in the proximal, at the very beginning of the vessel, the widowmaker, almost 99% obstruction, minded in a completely asymptomatic individual, in which this was found incidentally in a chest for lung screening. And I put two stents or devices that open the vessels in that ostial and proximal portion, with having good outcomes and disease free of those. Patients doing very well, and he was installed medical therapy. Of course, behavioral therapy for his heavy smoker has been initiated. We have not been yet successful, believe it or not. We're human beings, but we're in the process of that. So to wrap it up, in summary, my presentation was to allow how we can combine different imaging modalities, from cardiac computed tomography to nuclear medicine, and to finally intervention using angiography and fluoroscopy to save the life. That's why of the individual who presented asymptomatic and having a tremendous vessel stent in one of the major ones, which could have led to another individual, putting the statistics of sudden cardiac death as the first manifestation of heart disease. Thank you.
Thank you so much, Dr. Mendiolaza, for this extremely interesting presentation. I would just have maybe one question. I don't see questions from the audience. Your expertise goes beyond borders globally, and there are probably also some young doctors in the audience. So I would like to ask you if you would like to share an advice when you have cases like those patients, what an maybe less experienced doctor can do to possibly save their patient, to look for maybe less orthodox ways, and maybe sharing from your experience, look for some additional information to save patient lives.
Sarita, right? Am I right?
Yes. Yes.
Sarita or Sarita?
Zarechta.
Sarita, Dr. Sarita, thank you so much. What a very compelling question that you asked. Important. Yes, indeed. Of course, in the most humble manner, I acquire all this expertise throughout the years. But you point something very interesting. I was young at the time as well, and I know when I started, trying to learn, and you develop this over the years. But I guess a good history taking and listen to the patient. That oftentimes when we are out of training, as a cardiologist or primary cares, we just go sometimes, including myself at the time, fast and fast. But these scenarios allow us to be the importance of studying with patients based on risk factors and basic tools such as an EKG. Sadly, though, in many instances, 80% of these cases tend to be not being seen. And so, like in this scenario, the electrocardiogram, along with a good history taking, did allow me to. Have I seen patients who like this with nothing else, even normal electrocardiogram? Yes, I did. What happened to them? I would not like deny to you. I don't know. Because heart disease is sadly very, very, how put in this way, very unfortunate, very unpredictable. But yes, indeed, the only thing that I can advise young cardiologists nowadays, at least in the United States, is to learn the basics of computer tomography and imaging modalities. And in the United States, it's being forced because in every field, in every place that somebody wants to be higher, they are requiring to have these skills, at least in the basic manner. But yes, that's my only contribution. Listen to the patient, and that's it.
Thank you so much again. Thank you for your contribution to this conference. And I would like to move on to the next speaker, Dr. Hazem Reslan, pediatric dentistry specialist from the United Arab Emirates, who will present his second poster presentation on the treatment for immature traumatized central incisor. Dr. Hazem, the floor is yours. You're muted.
Good afternoon, everyone.
Hello.
Now, our presenting a case from my specialty is about traumatized central incisors. Actually, as we have discussed in the morning, time and appropriate treatment is important to achieve good results that will help to prevent the bad outcomes and enhance the overall well-being of the patient. In this case, the patient is 80 years old. He had a trauma like 4 months ago. Composite restoration was done on tooth number 8. As we can see in the first picture, there is a discoloration of the restoration and discoloration of the tooth. Pain on percussion was present, so the patient is seeking for a treatment. The patient is actually uncooperative, so we had to use the nitrous oxide inhalation sedation just to achieve a good cooperation, starting with the X-ray. X-ray shows open apex with resorption and periapical radiolucency, which means that there is a periapical inflammation. So the treatment plan was to do apexification using the MTA, then obturation with cotoberca, and next the final restoration. The treatment should be started with the isolation. Good isolation is a key factor for success of the treatment. Cleaning was done with actually a big size manual files, irrigation, with hypochlorite, saline, and chlorhexidine. Then the obturation was done with MTA as a plug in the apical area, then with cotabarca, and that was actually followed by a good composite restoration. After the treatment was done in the follow-up visit, after 1 week, after 2 weeks actually, there are no more symptoms. The patient is happy with his new tooth, smiling all the time, and actually that's what we were seeking, what we are looking for: the good outcome, the relieving of from the pain, and the confidence that patient is feeling right now. The following visit was in Ramadan, but due to the circumstances here in UAE, it can't be done. Hopefully next month we will see him. Any questions? I'm ready to answer.
Thank you so much for this presentation of your poster. I do not see any questions from the audience, and as we're running a little bit ahead of behind the time, I am supposed to go ahead with the next speaker. So thank you so much, Dr. Hazem, again.
So most welcome. Most welcome.
Thank you so much. I would like to go ahead and move on to the next speaker, who is Dr. Muhammad Ashar Hussain, cardiologist from India. He will present successful management of ACS in STEMI complicated by cardiac arrest and cardiogenic shock, a case report. Dr. Hussain, the floor is yours.
Hi, good afternoon.
Hello. Welcome.
I'm Dr. Azhar. I thank you all the organizers for giving us this opportunity to present at this platform at the Fifth World Cardiology and Cardiovascular Disease Conference. So I'm sharing my slides now. Is my screen visible?
Not yet. Dr. Hazem, your camera is still on.
Okay. Is my screen visible now?
Yes, now it is. Thank you so much. Please go ahead with the presentation. You have 15 minutes.
Yeah, thank you.
If you can go beyond that, it would be even better. Thank you so much.
Yeah, thank you. So I'm presenting a successful management of a complex clinical condition where a 67-year-old male patient presented to us This is just briefly about me. I'm Dr. Azhar, interventional cardiologist from India, Hyderabad city. Currently working as a consultant and interventional cardiologist and heading the Department of Cardiology at Glenfield Mallareddy Hospital in Hyderabad, India. So this is regarding 67-year-old male patient, Mr. G, who had a history of diabetes mellitus, hypertension, and chronic alcohol use. He presented to us with acute severe retrosternal chest pain with severe breathlessness of grade 4. On initial evaluation, he had tachycardia, respiratory rate was high. This was his initial ECG. If you can understand this ECG is very high risk ECG. Is showing ST segment elevation in some leads like AVR, V1, and diffuse ST depressions. ST segments are so low. So it indicates a complex coronary disease, either a triple vessel disease or a left main coronary artery disease equivalent. And many of these people who show these kind of ECGs are very high risk. They succumb in no time. So with this presentation, as it was anticipated from the ECG, within some time, patient developed severe breathlessness. Sorry. Patient developed severe breathlessness. He went into gasping stage. His heart rate fell down. BP fell down. BP was not recordable. He developed bradycardia, and he was started gasping. So immediately he was started with cardiopulmonary resuscitation as per ACLS protocol, and in 10-15 minutes we could resuscitate him. Spontaneous circulation returned. Then we got an ECG which was suggestive of like this, and it is again showing a tachycardia and poor prognostic features with ST elevations in AVR and diffuse ST depressions. So at presentation he had in some time he collapsed. Then his cardiac biomarkers came, and we got his cardiac biomarkers, troponin, NT-proBNP was high, and his 2D echo revealed severe global hypokinesia of left ventricle with severe LV dysfunction. He was having severe mitral regurgitation, and he was having moderate to severe pulmonary arterial hypertension as well. So then, as I mentioned, he collapsed. Then this was his. I'll show you his image at presentation. We could see the image of the patient on the right side of the screen. He was initially managed with non-invasive ventilation at the presentation. Then, once he collapsed, he was connected with mechanical ventilator. He was intubated and put on connected to mechanical ventilator. On the right side, you could see the image, and his blood pressure was low. So he was connected. He was started on high dose vasopressors, inotropes, and because his LV was so bad, he was started with decongestive therapy as well. And 1-2 medicines are for his sedation and paralysis on the ventilator. So now what to do? He has his course is complicated. He has severe left ventricular dysfunction. Blood pressures are so low that requiring high dose of vasopressors and inotropes. So there was a discussion with the treating me and our critical care team and the family. Then came to a conclusion that we will place him some mechanical circulatory support. So because his condition was so bad, so we placed him initially with intra-aortic balloon pump, IABP. So IABP was inserted, his BP started holding on. So then after informed consent, because it's so high risk and he had an acute coronary syndrome, acute coronary event complicated by cardiac arrest. Now the ultimate thing is to go ahead with coronary angiography and treat the and fix the blockage, whatever is there. So it was not the surprise, as the ECG mentioned, and his clinical course showed that he should be having a complex coronary disease inside. So we did his coronary angiography. On the left of the screen, we did this is showing a left main coronary artery trifurcating with what's called here trifurcating, and a distal left main coronary artery having a significant stenosis, followed by left anterior descending artery having stenosis, ramus intermediate having 90 to 95% critical stenosis, followed by circumflex artery whose ostium and proximal were fine, but just post the proximal segment it was significantly diseased. So now this is the LAO caudal view, and this is the cranial view which I have mentioned here. It is also showing a significant osteoproximal disease of the coronary artery, left anterior descending arteries, osteoproximal segment disease, and the right coronary artery is also diseased, which we can see in the right lower video of the coronary angiography. So now then after high risk consent, because at this stage ideally he is a candidate whoever has this kind of anatomy in the coronary arteries after a coronary angiography, they are usually are good candidates for coronary artery bypass surgery. But in unprecedented situations like this case scenario where patient collapsed, severe LV dysfunction is there, and patient had a cardiac arrest complicated by a shock and all. So because this disease has to be fixed, we cannot give time for a bypass surgery. So after informed consent and explaining the high risk, we did a high risk coronary intervention with the support of his IABP, vasopressors, and on mechanical ventilator. So what we did is we did coronary angioplasty on him. We passed 2 wires through this left main into left anterior descending and left ramus intermedius. So at this stage, initially it was very complex. So we thought we first dilated left main coronary artery. Then after that, we passed a balloon into the ramus intermedius, did a balloon angioplasty there, opened the stenosis with some balloon, prepared the lesion. Then we could pass balloon into the left anterior descending artery. We did a balloon angioplasty, opened the stenosis there. Now the plan of doing stenting came in because there was a significant disease in the left main and also significant disease in the ramus intermedius and also in the osteoproximal LAD. So at this stage, we did balloon angioplasty to the left main, balloon angioplasty to the ramus, balloon angioplasty in the left anterior descending. Now the plan comes. Now the situation came how to place the stent here. Initially, what we did. We tried to pass stent into the left anterior descending, which couldn't cross. So we took a short stent of 18 to 20 mm, 2.5, 2.75 into 18 mm. Then we placed that stent in the osteoproximal LAD here. This is the proximal part of left anterior descending, leaving the osteoproximal segment here, so that only short stent could cross. Then what we did is after placing a stent in the proximal LAD, because another stent it was difficult to cross. So then what we did was we did a balloon angioplasty. We did dilatation of the left main coronary artery stenosis. So then after that we placed a stent in the left coronary artery with a 3.5 mm into 18 mm everolimus eloting stent. Then this is the second video in the center is showing placement of stent in the left main coronary artery, ostium to the bifurcation. Then in the third video in the right side, now what we did was now we are stuck with the situation where left main is stented, ramus with distal left main to ramus and distal left main to osteoproximal LAD is diseased. So now that has to be placed stent with. So now what we did was we placed 2 stents simultaneously. We passed one stent. We passed one stent into the ramus here with 2 watts. We have done this procedure through femoral access. So the catheter which we are able to see, that is coming from the right groin, right femoral artery. So now this is left main is stented. This is the ramus intermedius with its osteoproximal segment, significant stenosis. Now we place the stent here. So simultaneously we placed another stent passing through the same guide into the left anterior descending coronary artery. Now with these 2 stents, proximal parts like one strut of each stent of LAD and ramus we placed into the distal part of left main here. Then now here this is stent. This is stenting simultaneous deployment of 2 stents, one each in ramus intermedius and the other in the osteoproximal LAD, overlapping the previous stent in LAD and keeping one strut each of the stent of LAD and ramus into the distal left main stent, so that all the segments of the distal left main, osteoproximal LAD and osteoproximal ramus intermedius are covered with stent segments, so that the everolimus which is eluted should suppress the plaque there. So now this is simultaneous stenting. This is simultaneous kissing method of placement of two stents with one stent each into the distal left main. And all this happening with the balloon here. We can see the IABP balloon which is placed already inside. Patient is on high dose vasopressors, inotropes, and on mechanical ventilator. And this is the last shot where after placement of the stent, yeah, this is the final angiographic shot after placement of the stent. This is the one. This is the one. The lesion in the distal left main is open. The osteoproximal LAD is open. Now osteoproximal ramus is also open. Now after doing this procedure, we finished. We removed the wire, and we after that we shifted the patient to ICU because he was on IABP, knocked off totally on ventilator with high dose vasopressors, sedatives. Then because his course was so complicated that he was having severe hypotension, uh, so because of which, and he developed sepsis, so because of which he had renal dysfunction. The creatinine was so high, it went up to 4 or 5. Then he had severe metabolic acidosis because of this shock and renal dysfunction, sepsis, which was multifactorial acidosis. Then after this procedure, we shifted him back to the ICU. Our critical team colleagues also helped with giving him high dose vasopressors, inotropes along with IABP. We gave broad spectrum antibiotics for his sepsis. Gradually, over 3 to 4 days, his course improved. His blood pressure started improving, sepsis started resolving, his anemia started resolving, and he was transfused with some blood. His liver injury improved, his coagulopathy, which he had, which got gradually improved. So his thrombocytopenia, all those improved. Then over 3 to 4 days of stay in ICU on ventilator with hydros vasopressors and all, he was gradually weaned off those vasopressors. Then we could remove on day 4 or day 5. His IABP was removed. Then he was extubated. Then his renal function improved, platelets, coagulopathy improved, electrolytes got improved. Then he was weaned off ventilator. He was extubated on day 5, day 6. Then after that, because we were monitoring with his blood parameters, coagulation profile, gradually those improved. He's because he was there in ICU for like 5 to 7 days. He developed weakness of limbs, but that gradually improved with supportive therapy and physiotherapy. All blood parameters improved. Then in the last, we could extubate. We could mobilize him. This is just a small video of the person, the patient. See, we could mobilize him on the wheelchair. Then after this day, he could be discharged on day 8, day 9 of the hospital stay. Now this is 6 months follow-up of the patient. He's still following us. He's happy, coming with family, enjoy. He is walking now, no chest pain. LV function, which was severely dysfunctional, then his LV ejection fraction was around 30%. It improved to 50% now, and his mitral regurgitation was severe then. It has improved to mild to moderate mitral regurgitation. Creatinine is totally normal. Muscle weakness, muscle power is totally regained. All the other parameters were significantly improved. He's very happy now, and whenever he comes, he gives praises us. He says that you have saved our life. So during all this management of the procedure, even the doctors, the staff, the other team's heart rate was high. We were tensed. We were worried how this patient might improve. But at the end, once we could discharge him, we were very happy that we could deal with such a case, and treated him and discharged him to his walking state. Thank you.
Thank you so much, Dr. Azrar, for your presentation. It was very, very informing and interesting. I would like to move on to the Q&A session. If there are some questions from the audience, please write them in the chat, or please raise your hand and I will invite you to ask your question very quickly.
Hi there. I apologize. I don't know how to raise my hand, but I don't know whether I can use the audio. May I?
Yes, please do.
Yeah, please.
Yes. This is Dr. Mendiolaza. Dr. Hussein, is that
Yeah,
your
yeah,
last name? Dr. Hussein,
yeah,
quite
yeah,
compelling.
yeah, yeah. I'm listening to you, Dr. Mendoza.
Thank you very much for your kind, impeccable presentation. It was quite compelling, actually. I got a couple of questions, given that the audience that may not have that much of an expertise in this field. But oftentimes, when we do patients who they have what Dr. Hussein depicted in a very impeccable manner, patients who they have an acute coronary syndrome, that in layman terms means heart attacks.
Yeah,
Heart attacks can present in a fashion like he depicted, in which the obstruction of the vessel that supplies blood to the heart is not totally completed, or in partially and some sort like the one that Dr. Hussein presented. But
yeah,
sadly, this patient got complicated with one of the things that we see more obviously when the vessel is completed, which is shock and so forth. It is
yeah,
very uncommon but can occur in the scenario that he depicted, having such an unfortunate outcome. And
yeah.
so, in those scenarios, you did a very beautiful presentation in terms of this case. Now,
Thank
when
you.
that occurs and you take the patient to save his life, to do what I did in the other patient, but not quickly, to open the vessel and not allow blood flow to the heart and restore the physiology and the potential death. In this
Yeah,
scenario, your team proceeded to do an aggressive therapy, given the fact
yeah,
that the patient was in shock, and that
yeah,
shock was that was hypotensive and impending to die if something was not restored, which is open the vessels. So
yeah,
the question comes: evidence-based and clinical guidelines express number one, patients who they have non-completely occluded can wait for the procedure. Nevertheless, in this case, the patient was in shock. So something has to be done, and your team proceeded accordingly. My
yeah,
first question is, when that occurs, to allow that heart to functioning while the procedure takes place, we need to help that muscle to
yeah,
improve and to pump. And we use a device which in the past is called balloon pump, but now in the United States we use Impella, which is a device that
yeah,
allows you to, while you're performing the procedure, to help you to supply flow to the vessels which are
yeah,
damaged and damaging the myocardium. So, number one, the question is for the audience to safeguard a patient's life. We use in the United States a device called Impella that is kind of like a squeezer to help the vessel while you are performing the procedure. Now, I don't know whether you guys use that or not. I did not hear that, or perhaps I missed it. Number two, when we address patients who they have that unfortunate situation, like in your case, there are some evidence-based guidelines, which is the culprit shock test, clinical trial and evidence base, in which, for the most part, in patients who they have with an impending cardiac arrest and death, in shock, the guidelines clearly says fix the culprit lesion, which is the vessel that is demanding or major culprit for the event. That could be the LAD that you show very much, and try to avoid to fix the other vessels that are blocked, because that will pretend portend more risky while the patient is in the in the cath lab. So the quicker the better. But I see that you guys did a multi-staging at the same time. So if you can elaborate to us if that device was used, and number two, why do you guys do the multi-staging instead of just the culprit based on the culprit shock trial? Thank you.
yeah. Thank you, Dr. Mendiolaza. And as per your queries, because one thing is regarding IABP or Impella or so. Regarding Impella, in Indian scenarios, because that Impella device is so expensive here, and IABP is easily available. It is not. It is I mean, less expensive. So we placed IABP here. And the other question regarding this culprit shock and all, because that is with ACS events and most of the people were STEMI, so that when multi-vessel disease is there, that applies there. Yes, you fix the culprit vessel and go. And this is non-ST elevation MI here, and here ST elevation is there, was there in AVR V1 and diffuse the ST depression. So it is showing either triple vessel or a left main equivalent. Now, as we did angiography, we could see distal left main a tight stenosis 70-80%, and followed by osteoproximal LAD and osteoproximal ramus. Now, this scenario will be excluded from the culprit shock study because they have excluded these kind of people. So now we are stuck with, as you mentioned, because it could have been a simple, like a straightforward one vessel disease or so. You would have placed that, fixed it, and come out that, as you mentioned, and as the guidelines also say, that you fix it as rapid and as short as possible, staging the other vessel. And we did here, because the distal LCX, even a good sized vessel, we didn't do anything. We staged it. And right coronary artery, it is diseased from osteoproximal to mid and occluded in the mid segment. So now this left main was unprotected as well, because if right coronary was giving blood supply to the left, then it will be protected. Now this right coronary is also occluded, so this is a unprotected left main with involvement of osteoproximal LAD and ramus. So at this stage, because left main is significantly involved, placing a stent just into LAD, leaving the osteoproximal part or leaving the distal left main wouldn't have been an adequate procedure. So we could do this. We had to do this at that time because this was a disparate situation. So we had to do this at that time.
I would like to just interrupt, if you wouldn't mind, and invite you to connect with each other and continue this conversation offline or in another setting. And as we already have only 2 minutes to actually close this session, I would like to kindly ask if there is any other question. And as there is no, I would like to very, very warmly thank to all of the speakers, all of the distinguished speakers who were participating into this afternoon session. And I'm inviting you for the tomorrow's morning session as well. And please stay tuned for more information about the conference. Thank you so much again for your participation. Goodbye.
Thank you. Thank you, Dr.
Thank you.
Mendiolaza.
It's a pleasure as well. Thank you very much. Outstanding.
Thank you. Thank you.
Outstanding.